Hi, Mr. Bailey.
Hi there.
Hello, hi, I'm Dr. McDonald. I've just come to talk to you about what's been going on since you've come into hospital and the treatment you've had and the investigations we've done. Just before I do that, how much do you understand about what's happened and what we've done so far?
Well, I came in with racing heart,
Yep.
and the doctors had a look and tried different things to try and get my heart to go back to normal beat.
Yep.
And got some medication, and it's gone back to normal, and I'm starting to feel a lot better now. So
Okay, good. The information I was given about you said you felt quite lightheaded when you had these.
yeah,
And you had palpitations and
yeah. Well, when they started happening, I just felt a bit dizzy, a bit lightheaded and things. But obviously now it's back to normal. I'm feeling quite well actually now.
okay. Has anyone talked to you about the tests that we've done or any results that you've had so far about that?
No, not yet.
Okay. Well, the as you know, we did an echo of the heart, echocardiograph. It's sort of an ultrasound scan of the heart when they put the gel on your chest. I'm sure you remember that.
Yep.
And the very reassuring thing about that is that the structure of your heart looks normal. So your heart's shaped like a normal heart, has all the right bits in all the right places. But you're obviously a young chap, and this is a quite unusual problem to have when you're young. And we think we've identified what's going on. And your heart is essentially a pump. It pumps the blood around your body, as I'm sure you know. And it's to do that, to coordinate the pump, to make sure all the chambers of the heart move in the right coordinated way. There's a wiring system in the heart. And what we've seen on the electrical tracing of your heart, which monitors how the electricity passes through that wiring system, what we've seen is there's a short circuit there. Does that make sense? So
Yeah.
instead of your heart beating in a nice coordinated way, every now and again the electrical current is escaping around a little loop and going round and round very fast. And that's making your heart beat very quickly.
Right, okay.
And we can see evidence of that on your heart tracing. Now sometimes that's because there's a structural abnormality in the heart. There's something about the anatomy or shape of the heart that's different. But in your case, the anatomy of your heart looks normal. But we think that you've got a very specific type of electrical abnormality. It's called Wolff-Parkinson-White syndrome, which is named after the people who discovered this abnormality. I can write that down for you later.
Thank you.
If you want to go and look up and read things about it. But what I need to talk to you about now is what that means for you and what we're going to do about it and how we're going to treat it. So in the first instance, I don't want you to worry about this. We've got you on medications that have got your heart back into a normal rhythm, and that medication is something called amiodarone. And that should also prevent you going back into an abnormal rhythm again. Okay, so it not only treats the abnormal rhythm and it's got you back into a normal heart rhythm, it should prevent you from going back into having palpitations and a racing heart.
Okay, yeah.
Again. And you'll need to take the amiodarone until we can do something more definitive about the problem. And there are a few side effects and problems that some people get taking amiodarone, which I'll talk to you about in a moment, and you need to be aware of. But really, we're only keeping on the amiodarone as long as we need to until we can do something to stop this short circuit in your heart. And pleasingly, there is something we can do about that that's usually very effective. Okay.
Okay.
So I'm afraid, although your heart's back in a normal rhythm, if we want to stop it going back in the long term, we'll have to do a procedure to ablate and get rid of this short circuit in your heart. Does that make sense?
Yeah. What's a surgery?
So it's not a major operation with a general anaesthetic, and you don't have to have your chest open up. No one's going to go into your heart and do anything from the outside. This is a procedure that we do by passing a wire up into the heart, and the wire usually goes in through one of the vessels in the groin, sometimes the arm, and there's local anaesthetic there so it doesn't hurt as it goes in. And they pass the wire into the heart, and we use the tip of the wire to work out where the electrical abnormality is in the heart. Does that make sense?
Yeah.
So we, and when we find it, we can ablate it. And again, that doesn't hurt. We use heat to ablate it, but it just kills a very small number of cells just where that abnormal bit of wiring is to stop the short circuit. Does that make sense?
Yeah. So I know there's no pain here, but is there pain when it's inside you?
No, usually, and you shouldn't feel the actual ablation process because there shouldn't be no pain receptors on the inside of your heart that will register that. Some of the symptoms you do get, to see where the wire's going, we inject some contrast. So sometimes you have an unusual warm sensation as the contrast goes in. That's very common. But it's very unlikely you'll experience some discomfort. Sometimes you can get at the groin afterwards a bit of a collection of blood or a bruise.
Right.
We can talk more about the procedure when we come nearer to it, and you can talk to the consultant who's going to do it, and they can talk you through everything that's going to happen. The procedure is a successful one, so it has about a 90% chance of sorting out the problem for good. Okay, so although on the one hand you've got a problem with the heart that can be quite a worry, we can do something about it that's usually very successful. And by success, I mean we can take you off the medications that we were using to keep your heart in a normal rhythm. Does that make sense?
Yeah, but if I didn't have the procedure and I just kept on the medication, would I have effects long term? So
all medications have to some degree effects that are undesirable. The one that we've got you on at the moment, the amiodarone, has a few effects, which means that where we can avoid it, we don't want to use it long term. And it's also not as effective, usually in the long term, as the treatment at keeping your heart in a normal rhythm. And the risk with Wolff-Parkinson-White syndrome is that you could not only develop the racing heart you had this time, but a problem with the heart where it stops beating effectively. Instead of pumping even faster as you had, it just doesn't pump at all, it just sort of twitches. And that's what we worry about. Okay. And amiodarone will reduce your chance of that, but if we can ablate this pathway, we'll reduce the chance of that much more, and hopefully stop it from even being a possibility. Does that make sense? So first of all, the treatment's more effective than medication. The medication also has side effects. Now, I hope that we'll be able to do this procedure very soon, so the amount of time you're on the medication will be limited, and so your chance of developing problems is much lower. So these are usually problems that we see in people who've been on it for 6 months or more. Right. Okay, and we'd be anticipating doing your procedure within weeks. Okay. If not sooner. So the main things we worry about are, first of all, that your thyroid gland can become either overactive or underactive taking amiodarone.
What's that?
So your thyroid gland is something that usually controls your turnover of energy in your system. So if you have an overactive thyroid gland, you tend to burn more calories, lose weight, feel hot all the time, feel a bit agitated. If you have an underactive thyroid, you can gain weight, feel cold all the time, feel generally lethargic and slow. And but we will keep an eye on your thyroid function test. If there's any sign of that happening, we can act accordingly. We can treat an overactive thyroid or an underactive one. The other problem we worry about with amiodarone is that it can have effects on your lungs. So a small number of people who take it can have a reaction where they get inflammation in their lungs. Now that can be long-term chronic inflammation, but it can lead to some scarring on the lungs if you're taking it for a long time. But again, this is usually a problem we'd anticipate if you're taking it for 6 months or more. Does that make sense? Very, very rarely people can have an acute reaction like a pneumonia to amiodarone, but it's very unusual. Okay, so it's probably less than 1% or 1 in 100 people have that. Okay. Right. There are other very common symptoms you can get. Some people get a bit nauseous on amiodarone. Some people get small deposits in their cornea, which is just the translucent part of the eye, which can make bright lights sometimes seem as though they have a halo of light around them. Now that's almost always reversible, so it goes away after you stop taking the medication, and very rarely interferes with your vision, so it shouldn't affect how clear your vision is. Okay. So these are the major things we worry about with amiodarone, but some people take it without any problems at all. Okay. In fact, the majority of people won't have these, but it's important we warn you about them. So if they do develop, we can act on them and treat them. And we'll be keeping an eye on your blood test while you're taking it. So as I said, so all of these side effects, I have to make very clear, are usually more common the longer you take the medication. We're hoping you'll be on a shorter course. But you can still get some of those side effects even on a short course. But unfortunately, it's the only thing we found that will control your heart rate at the moment. Okay. Is this all making sense? I mean, I know it's very worrying to hear about a problem like this with the heart. It's always very anxiety-provoking.
It is, yeah. I haven't had surgery before. I'm a bit concerned about the procedure.
It's a lot of information to take in. I mean, and it must have come out of the blue for you to suddenly have a racing heart and then find yourself facing all these things. I think the important things to remember are that this is, if untreated, this can be dangerous. But and some people actually present with a potentially much more worrying problem with the heart than you have. So the heart can, as I mentioned, there's that risk of it stopping beating effectively. But now you've presented and we know and we've seen it and we've got you on the medication to stop that happening. So the chance of that happening is now very, very small, and we can now do something definitive about it to stop it happening in the future. Okay, so you've probably always had this short circuit in your heart, and fortunately we've discovered it in quite a benign way, so in a way that hasn't caused you any harm or long-term harm, and we can get on and do something about it.
So why do you think it's like suddenly come on? Is it just because if I've had it since I was born, how is it?
It's a very, very good question. I'm not sure anyone really knows the answer to what precipitates the first event of things short-circuiting in that way. But there are various hormonal factors that might cause it. There might be changes in your heart structure as you grow or exercise, and so on and so forth. There could be numerous causes. No one really knows what causes the first thing. And some people will have this condition and never present to a doctor, and they'll live a full life and die of something else completely unrelated in old age. So for some people it doesn't even cause problems. They have the abnormal wiring, but it doesn't ever cause the palpitations or the racing heart as you've had.
And if I have the procedure, is there any chance it could come back? I mean, or is the procedure?
Well, as I said, it's about 80 to 90% successful. So if we take 10 people who have this procedure, 8 or 9 out of those 10 people will not have a recurrence afterwards because you can ablate the pathway. In those that it does come back, it's not the end of the world. Usually it means that there's another pathway that we've missed and we need to go back and find and ablate that. Or there are numerous pathways, or we can't do that in a very small number of people, and then they need to take medications long term. And then we can try and find a medication that has perhaps fewer side effects than amiodarone that would work. But the chances of that are small. So the chances of a good, successful procedure, definitive procedure, are very high. And that's why this is the recommended therapy for this condition.
Okay, yeah.
So it's a lot of information to take in. I think the most important thing is that it's very good that we've caught this and there's something we can do about it. So hopefully in a month, 2 months' time, we can be looking back at this as a solved problem, okay? And you won't have to worry about it in the future. Yeah. So I'd focus on that. You will, in the meantime, before we do that, have to take these medications, the amiodarone, which does have side effects in a small number of people, okay? But we'll monitor you very closely to make sure you don't develop those. When we get nearer the time for the procedure, we'll go through all the pros and cons, the risks and the benefits and so on, which I've mentioned today. But the important thing to remember is that it's 90% successful, and the chance of having a serious problem during the procedure, by that I mean your heart going into a potentially worrying rhythm or you having another complication, is very small. Okay, again, probably less than 1%. All right. So if we did it to you 100 times, we'd expect only on one occasion for it to go wrong.
Yeah.
And I think we have to weigh that up against the risk of doing nothing or leaving you on medications long term, which won't completely control things, and there's still a risk you'd still get a heart arrhythmia or a racing heart again, perhaps even a more worrying heart rhythm, which meant that your heart stopped pumping properly. And on no treatment at all, I'd be very worried about continuing without any treatment, medical or otherwise. Does that all make sense?
Yeah.
So we're going to get on and do this as soon as we can. In the meantime, we'll keep you on the amiodarone to keep things under control. And then hopefully, there's a very good chance after you've had a definitive procedure that you won't have to worry about it again.
Okay.
Does that all make sense?
Yeah.
Obviously, we'll meet again before the procedure. If you have any questions at all about it or anything else you want to ask more questions about, if you want to go and look it up, I'll write down the term for you so you can find out some things about it. Bear in mind when you do that, there's lots of information that may not be relevant to you. Okay, so there are people who have variants. There are lots of different variants of this condition, some more worrying than others. All right. So there aren't necessarily, if you go onto the web and find things about Wolff-Parkinson-White that you're very worried about, feel free to discuss them with us. Yeah. But it's unlikely they'll necessarily apply to you. Okay, and the important thing to remember is you're on a medication now that should stop you having any problems until we can do something about it.
Okay.
Okay. Right. So we'll meet again shortly and discuss the procedure. Okay. This is a very difficult communication skills scenario. There's an enormous amount of information you have to get across to the patient. You've been asked specifically to explain to him that he will require ablation of his accessory pathway for Wolff-Parkinson-White, and you're even given data about the likely success rate and the complication rate. But this scenario is about more than just consenting someone for procedure. There are also the risks of amiodarone, which the scenario instructions don't mention, that you definitely have to convey to the patient and make sure they've understood. And there's another issue here, which is breaking bad news. You're explaining to a young, fit person that he has a potentially fatal underlying conduction abnormality, and you have to explain that to sort out this problem is going to involve a relatively major procedure. I think in the exam the candidates would be expected to convey all that information in a way that doesn't completely bamboozle the patient. And I think the important thing to do is to make sure at every stage when you give the information that's been understood. First of all, as with all these communication skill scenarios, you have to establish what the patient knows and understands about his diagnosis. In this case, very little, and you have to do your best to explain what's going on. That's an essential foundation before going on to explain what the treatment is. And the strategy in this case is to explain that amiodarone in this case will control his arrhythmia to some degree, but it's not definitive treatment, and it does have side effects. First line therapy, of course, ablation therapy, and I think the best way to communicate this is that we've fortunately picked up a potentially very dangerous arrhythmia, and we're now in a position to treat it in such a way that he won't have to worry about it again in the future. It's well known that patients tend to take away about 3 pieces of information from any consultation, and there's a real risk of information overload in this scenario. Once you've explained the diagnosis of Wolff-Parkinson-White, then gone on to explain the many and various risk factors of amiodarone, and then gone to discuss the risks and benefits of ablation therapy, you've probably left them with far too much information, none of which, or very little of which, they'll remember. Important then just to stick to 3 major points, and you can always have a strategy at the end of the consultation to answer their questions at future meetings.